So good morning, good afternoon, good evening, friends, depending upon which part of the world you are joining us from. I can already see from the chat bot people joining from different parts of the world for this much awaited program, which is there on first Tuesday. This happens to be our 10th international webinar between ISQua in collaboration with CAHO, and a much sought after topic today, that is infection control risk assessment. And to moderate this important session, we have Dr. Sandeep Murali, who is a consultant surgeon. He's a general surgeon as well as a laparoscopic surgeon, and he's the director of the Sitapati Clinic and Hospitals. He's a person who has been trained at the in UK at the I think at the Royal College of Surgeons in Edinburgh, and he has, I would say, tremendous experience, of course, both as an administrator and as a clinician. So therefore, he is one person who understands the importance of this whole topic. So to introduce the topic, as well as to our international speaker, Dr. Elorrio, I will request and hand over to Dr. Sandeep Murali to please go ahead and moderate this session. Thank you.
Thank you, sir. Thank you for the kind words. Welcome, everybody. As I said, it's probably the widest audience I have ever spoken to, so it does make me a little nervous. But having said that, good morning to people. I think Professor Garcia would be very early in the morning, as he said. Good afternoon to some and good evening to the rest. And some who are awake late night listening to this, which is a very important topic. This is the 10th CAHO ISQua webinar on infection control risk assessment. We all know that patient safety has become the cornerstone of healthcare across the world. And one of the key aspects of patient safety has become infection control. Infection is something that we don't want. As clinicians and as a surgeon, we know what it means. And as a patient, it involves a lot of morbidity, mortality even, and a lot of cost, not only in terms of man hours lost, but the actual hospitalization cost that may be there. So once an infection sets in, we all know that we are fighting an uphill battle, and therefore an ounce of prevention might be worth a pound of cure, and nowhere else is it more valid. And therefore, prevention has become the cornerstone of quality. And a lot of institutions and bodies across the world are pushing for prevention of infection and monitoring of infection as one of the key quality indicators, rather than treatment, which all of us as clinicians may know. And therefore, the crux of this talk would be how you set up a risk assessment process in your hospital. What are the areas that you would identify? How do you go about making a change to your infection control policy? Where to begin? What is infection risk assessment? And how do you make a change, monitor it, and make a difference to infection in your administration? And there is no one more equipped to make this talk than Dr. Ezequiel Garcia-Elorrio. It's my pleasure to introduce our speaker for the day. He's from Buenos Aires in Argentina. He's a professor of public health and in the School of Medicine in Buenos Aires. And he's a founder and board member of the Institute for Clinical Effectiveness and Health Policy, and leads the Department of Healthcare and Patient Safety. It's a key nonprofit organization in generating and promoting scientific evidence towards patient safety in healthcare. Dr. Garcia-Elorrio obtained his medical degree from the University of Buenos Aires and specialized in internal medicine there. He went on to his education in the United States, which culminated in a public health degree from the Harvard School of Public Health in Boston, USA. He also has a master's in business administration and has PhD in medicine. So his academic qualifications are just too much to list, but I'm just giving you the gist of what all he has done. He has a very active research and academic interest with over 40 peer-reviewed journals, and he's a part of multiple research groups, not only in Latin America, but across Europe and Asia, and has received funding from the WHO, Melinda Gates Foundation, and a lot of other organizations which are involved in improving the health across various countries. He is the deputy editor of the ISQua journal and has been involved in health and safety policies across Latin America. It is my pleasure to hand over the presentation to Dr. Garcia-Elorrio to take over from here.
Well, thanks, Dr. Murali. Thanks to CAHO for the invitation. It's a pleasure for ISQua to be part and partner of CAHO on this initiative. Thanks for the attendees for joining today. Good morning to you, for the ones who are near me, like Carlos Gonzalez from Panama that's joining today. And then we have people from all over the world. So good evening and good afternoon for all of you. It's a real pleasure again to be today with you. Let me just share my presentation for a minute. Control risk assessment. And I wanted to add the word patient safety to it, because we are all into patient quality of care and patient safety. So trying to talk, not being an infectious diseases specialist, from the perspective of patient safety, I would like to share with you some thoughts and information about this strategy to decrease the burden of hospital-acquired infections in hospitals and healthcare facilities. And it links to patient safety, as well to some examples from Latin America. You know, the world is big, lots of things are happening at the same time. Of course, COVID has affected how we live and how we deliver care everywhere. So hopefully you will find in this presentation information that will be useful for your patients, the population you have in charge, and hopefully for the health systems you belong to. So going to that, again, the goals of the presentation are to discuss about the infection control risk assessment strategy that's being used to prevent infections whenever health facilities are built and maintained. Then to link ICRA to patient safety and quality improvements for some examples that we have conducted in Latin America, not mainly related to ICRA, but mainly how to sustain the evidence that we should be delivering to patients whenever we're trying to address hospital-acquired infections. So hopefully that's interesting for you, and I will be glad to talk for no more than 30-45 minutes and have the chance to respond to questions that hopefully I can address. And finally, please know that I have already shared my slides with CAHO for them to be distributed as they're willing to among you and others. Thank you. So a small comment about IEX. IEX is a research organization in public health based in Argentina, down South America, and where Argentina has 2.5% of the population of India. And we are from there, we are trying to contribute to the healthcare in Latin America region and eventually around the world. We have projects in 30 countries of the world, including India, about some years ago. We work in mother and child research, education, healthcare quality and patient safety, chronic conditions research, and health economics and health technology assessments. Those are the main topics of our work, and our mission is to contribute to improve global health through the generation and promotion of best scientific evidence. And the case for infection control is that we are not in the business of generating evidence. We are in the business of implementing it. And the failure of the health systems across the world, particularly in low-income countries, is that we're not applying the evidence that we should be applying into healthcare. And that's the case of implementation science, something that we have been working strongly in, just trying to bridge the gap between evidence and practice. I'm sure that you have all known yet about ISQua. ISQua is a global organization working in the field of quality of care that has been happening for almost 30 years. The network of ISQua spans among 80 countries in 6 continents, and all healthcare providers are part of ISQua in all roles and terms. So it's a pleasure for CAHO to have been hosting us during these webinars and hopefully for future work. And again, we are all invited to join ISQua and contribute to the global endeavor of improving quality of care, particularly during these pandemic times, which has shown the inequities and the weaknesses of health systems especially in the less resource world that our countries are. So let me just hide my, so good. So some facts about healthcare infections in low-income countries. So as you all know, HAIs are a healthcare program across the world, and it's higher in our regions. The frequency is nearly 3 times higher than in developed countries. And the case of antimicrobial resistance, it's also increasing and increasing. And as you will see later, this is even worse after COVID. As I mentioned, the antibiotic resistance is increasing worldwide, and again, it's even higher in low-income countries. The misuse of antibiotics has contributed to this, becoming a serious threat to public health, and that caused by the case that we have higher incidence of mortality and prolonged hospital stay. COVID showed that extended hospital stays are a luxury because beds and resources are needed for other patients. So the case of prolonged hospital stays that may not even affect the morbidity or mortality of patients in the long term are a huge problem for everywhere. So, and whenever we are administering antibiotics, 20% of them may suffer from adverse events that could be prevented. So that's the business case for hospital-acquired infections in our countries. Why care about infection control? You know, from years, I have calling infection control professionals as the heroes of quality of care that had been working on this field for more than 40 years. And they have been only recently heard for all the work and praised for all the work they have been doing for so many decades. And why we should still care about infection control today? Because we can no longer rely solely on antibiotics. Antibiotics are not enough to address infections. We need system changes and systems activities that prevent hospital-acquired infections to happen. Because I have just said there are increased rates in hospital infections, and patients who get infected stay longer in the hospital. They may die. As you know, the increase of the likelihood of dying is higher. They're treated with toxic and less effective drugs. As increased microbial resistance appears, we had to use drugs that might be more toxic for patients or could be less effective. And finally, these patients have even more chances of having surgical site infections that may arise because of procedures that has to be performed during the admission in the hospital. So this is a paper from 2016 that describes the case for patient safety in 2030. Okay, almost 10 years from today. And 5 years ago, the case for patient safety was based on quality, because safety is an essential component of quality, mostly because of the preventable harm rate that could be decreased. Then the economic case, because more unsafety, it's unsafe care, it's an economic burden, which is mostly waste. Waste is the word that we all hate in some way because we are into quality of care. And finally, political. Politicians are starting to pay more attention to the case of patient safety, because lots of resources from economies are going to healthcare increasingly as people get more access to healthcare, but also they're getting access to unsafe care. So that waste that we know it's happening, it's affecting the performance of health systems and the level of waste. So politicians are paying more attention to us. And as you may know, the G20, whenever I would say the most influential countries in the world are gathering, for some reason that I cannot understand, Argentina is among those. The G20 is addressing the case of patient safety and antimicrobial resistance in their healthcare agenda. In the 3 topics that the G20 discuss every year, antimicrobial resistance is one of them. So you may have seen and understand the importance of this topic for the health system, for health systems across the world. So whenever we're talking about the challenges for patient safety, this report describes 4 of them. First, the increasingly complexity of cases that is related to increased complex care because of technology advances. Then, as I already mentioned, constraints in budgets everywhere. There is no country that is every country is struggling with budget constraints. And finally, as I mentioned already, antimicrobial resistance. So if you haven't already read this report, it's not that long and have a very nice roadmap highlighting the importance of patient safety for health systems worldwide and even before the pandemic. So here I just highlight the alternatives, I would say the different components on how to address antimicrobial resistance. And you have research and development, antibiotic conservation, trying to prevent antibiotic administration, awareness, surveillance and monitoring. But here I'd like to highlight the importance of sanitation, hygiene, infection prevention, and control. And here is why ICRA has a participation in trying to address the importance of hospital-acquired infections. So the problem that we're talking about is that facilities host multi-resistant germs. So hospitals and other healthcare facilities are the host of germs that usually are multi-resistant, and as already has been described by WHO in 2011, 1 in 7 patients will develop healthcare-acquired infections during hospitalization in low and middle-income countries. In developed countries, it's 1 in 20. So multi-resistant germs are a frequent cause of hospital-acquired infections, as we all know. Unprepared facilities offer lots of opportunities for germs to contaminate constructions and to colonize patients and providers. And the SARS pandemic has put a lot of pressure on hospital design and flow. What this last thing means, that hospitals weren't prepared for the flow segmentation of patients that COVID required. As you all know, hospitals have been segmented, had been divided in different flows of patients, non-COVID and COVID patients, and the risk of being contaminated with other germs has even increased because facilities wasn't prepared to divide their flow of patients and to be overburdened that they have been by the flow of patients that was huge in different parts of the world. So this is on the right, you may see like whenever we are trying to address hospital-acquired infection surveillance systems, the planning, where we're trying to assess how the providers and facilities are prepared to deliver the care safely, the care they should be providing. Well, the first step of planning is the one that ICRA addresses. So this is the last reference where we are trying just to mention that this is a paper from 2013 that highlights the importance of how the built environment plays a significant role in the transmission of pathogens in healthcare settings. So, you know, the case for construction and infection prevention has been around for a long time, but rather recently, maybe the last 15 years, there have been enough evidence to highlight the importance of preventing infections whenever hospitals are built. We're not just saying whenever we need to wash our hands to touch a patient. Just this is even before, much way before, whenever hospitals were built. So this is just a framework that's just trying to, in yellow, mention the importance of the hospital reservoir as a source for germs in whenever healthcare is delivered. you can see how important in light blue, hand hygiene and other barriers may prevent colonization in patients along patient flow. But again, we are highlighting here the importance of trying to prevent and eliminate, disinfect, and decontaminate different construction facilities that have been constructed or maintained that could relate to these different chances of getting a hospital-acquired infection during admission or being treated even in an outpatient setting. So again, ICRA is a multidisciplinary, organizational, documented process that, after considering the facility's patient population and program, that focuses on reducing risk of infection, trying to work through phases in the facility planning, design, construction, renovation, and maintenance, and trying to coordinate and waste knowledge about infection, infectious agents, and care environment, trying to anticipate potential impact. So this is care the way it should be. We should be aware on the importance of preventing healthcare infections while facilities are being either planned, built, or maintained. So there are 3 phases in ICRA. As you may have seen, I have tried to put references in all my slides for you to eventually go into them whenever, if you'd like to expand about more knowledge about this critical activity or system intervention. And again, my slides will be available for you after the presentation. So again, the design phase is trying to have a long-range planning. Hospitals are not built in 2 years. Hospitals should be built in even more time, because their planning in all ways, in all aspects, should be considered way before the contraction starts. So we need to have a sense of the number, location, of type of airborne infections, and isolation and protective rooms that should be available. We need to have an understanding of special ventilation and filtration requirements that may be needed, how air handling and ventilation needs on particular sites of the hospital, like surgical devices or surgical services and other sections of the hospital that might be at higher risk. And also water systems that could be contaminated, like, for example, for Legionella. So again, there are lots of ways that germs could be present in hospitals, and we should address and should be prepared for those. So whenever we are on the construction phase, we need to, of course, try to identify which are the highest. I'm trying to show a risk matrix for that in a minute, but we need to be sure on how to identify specific hazards to be prevented. Also, hospitals are not built at one moment in time. Sometimes they're built in different phases. Sometimes they're renovated. So whenever construction it's being developed, it's being conducted, we need to be sure what patients should be relocated for their susceptibility to infections. Just preparing for my talk, I talked to my colleague that works in infection control, and she had received during the weekend the cultures from different sections of the hospital that were renovated, and they got aspergillus. So they had to move patients from sections that were close to that construction work in order to prevent them to be infected, especially if they were immunocompromised. So, and that's happening every week. So every week they're looking for chance of finding certain fungi or other germs that could be of risk for patients. So the construction phase is dynamic and still it's a moving target along the daily work of infection control professionals. So, and also finally, the mitigation phase. Again, as I mentioned, patient placement and relocation, having standard for barriers that hopefully may protect, as you may see during the renovation of the hospitals. You may see physical barriers that are deployed to prevent patients to be contaminated, as well as providers that could contaminate patients. Again, temporary provisions or trying to phase in the construction in terms of heating, ventilating, air conditioning, and water systems to prevent contamination of those that may affect patients and providers. Again, also protection for demolition, things like those that, of course, could be of importance whenever you are trying to address the chance of patients to be contaminated. So this will go fast, but just trying to have a sense. The first question will be, what type of work needs to be done, specifically just trying to address for dust generation and spore aerosolization, some bacteria that could be found as spores that could be easily aerosolized whenever demolition or other activities are present. So you have things like drilling, flooring, removal of building structures, or complete demolition. Those are different stages or different risks for dust generation and spore aerosolization. And again, duration, hours, days, weeks, months. Then, this is very important. We need to identify what type of construction we're going to conduct. So this is for you to read on your own, because there's too much information, but there are 4 types of construction. Type A is just inspection and non-invasive activities like electrical trim work, or minor plumbing, for example, or work covering replacement. Then you have type B, small scale, short duration activities that create minimal dust. Short duration, 1 day. Just a small personal comment. My house is under renovation, and you will know how much I learned about the types of work that could be done at the construction. So again, type B, it's the other thing that is the other stage that you may consider. Type C is the work that generates a moderate to high level dust or requires demolition of removal of any fixed building components or assemblies. Here we have new wall construction, major cabling activities in the electrical installation of the building, duct work, things like you all may recognize in your daily work. Then you have type D, which is the highest the most invasive type of construction, where requires major demolition and construction projects. Well, and here are the ones that requires workshops. For example, that's important because different people that may be in contact with different germs that will be transmitted along different shifts in the hospital. Again, heavy demolition or new construction. So I just mentioned the 4 types of constructions that you may have in mind. Then where? As I said, a nursing unit, the hallway. In a nursing unit, for example, the hallway, the patient room, ceiling, flooring, inside the nurse's station, what kind of patient care area. The occupancy is that occurring during business hours, nights or weekends. You may see that several hospitals are built over weekends, renovation of that during weekends, because not trying to be related to that many healthcare providers running around the hospital, many patients. And just for, again, whenever you're trying to combine the 4 types of constructions that I already mentioned, you have to relate them to different types of patients or sections of the hospital. So low risk are outpatients office areas. Medium risk are, I would say, sections of the hospital like clinics or complementary imaging like endoscopy, nuclear medicine, or radiology. Then higher risk, like the coronary care unit, emergency room, labor and delivery, all those things are listed there. And then the highest risk are patients that are immunocompromised, in immunocompromised areas, the burn unit, the cath lab, oncology, operating rooms. As you can see, a different range of sections of the hospital that should be considered. And why we are describing that, we're trying to identify the type of construction with the type of patients that may affect, because the actions are different. And this is a very classic, from what I found, I would say, matrix that combines the risk and the different, just trying to look, because I have been talking without any camera, so just trying to see if I receive any hints of if I'm doing well. But I would say here that the infection control matrix will combine the efforts of the patient risk group and the type of construction. And always a wise manager looks into the bottom right of charts, and you can see that all the reds and on the right and on the bottom of the graphic of the table that I'm sharing with you. And you may have seen that there are different actions that could be taken. And briefly go over this. Here you have a number of recommendations related to the way to separate constructors to patients, how to filter the air, how to isolate different ways of isolation, the dust from air vents, or different ways of preventing germs to reach patients or providers. So as you can see, you have a list of activities during the construction project and upon the completion. So this is self-explanatory itself. So this is for you to maybe read if you haven't been already informed about this, and hopefully you will find out ways to eventually apply in your own systems. So what I have already did for the moment is just trying to cover the importance of ICRA, and going to the awareness piece. It's important to recognize hazardous materials, to control exposure, to identify routes of entry, to understand the health effects that may affect hospitals. You have to also be aware that all the hospitals are being renovated because of the case of asbestos that has been highlighted recently, well, recently for a number of years, but now there's more interventions that they're trying to accelerate the renovation of the hospitals that have been built with some kind of asbestos inside of it. So again, you will see a lot of renovation. I have been reading about the increasing construction in hospitals around the world that exceeds the global development of any country, because for some reason, hospitals are being built in more frequency around the world, or being renovated to be at the level that it should be to provide care in either any country in the world. So we need to be aware of site-specific considerations, understanding work practices from different construction teams, and again, well, the importance of understanding that whenever you are building in a hospital, you might be affecting people's lives. Here you have a number of organizations from the US that are regulating construction. The information that I have been using for this presentation, it's derived from the American Society for Healthcare Engineering. So that's something hopefully that you have been already aware of. And there are a number of organizations that you might also, especially that are in the field of infection control, that you may have been aware of. So what's being changed in healthcare construction? That pre-construction activities have increased, because now they're planning for patient safety too. That barriers, negative air, material delivery and storage, increased understanding of the work environment, and continue life safety during the work it's being done. And we, as I mentioned already, we are people that are working in this field are trying to classify their building to patient risk groups. So construction infection control is headed to becoming the normal process for doing construction. There is an increased understanding by all parties that for practice to happen. There's increased oversight by regulatory agencies. Hospitals are being cited for construction infractions around the world. This is even happening in my country, which doesn't have very strong regulations for constructions in healthcare. Record keeping and protocol is studied in the past, and those in charge are more cognizant of things that are affecting hospital care during constructions. And well, this is translating to other industries like schools or high-tech manufacturing. So hopefully this is becoming the standard. And again, we are all in patient safety because we want to prevent preventable harm. And this is a very good example of it. Well, here you have a list of, as I said, of references that you can use for learn a little more about ICRA, or maybe getting in touch with people that are working in this field currently and may have more information that I can provide to you during this presentation. So I will take a minute to breathe for a second and take a sip of water. I'm seeing there are some questions already, so hopefully I can address those whenever we are done. So, and just share a little bit about Latin America and infection control. Latin America, it's a region of the world that have growth in levels of demand and health spending, and the investment in healthcare had mixed results. Latin America is being seen around the world as a region with resources and not doing enough with those resources whenever we're talking about healthcare, because the level of spending according to GDP by different countries is not that bad compared to other regions of the world. The state governments are highly regulating healthcare. They're very active in the way in providing healthcare, 50 to 60% or even more. In my country, it's about 90% because the government influences very heavily either public services or the social security. That's the case for many other countries in Latin America. There are high levels of waste and fragmentation and misaligned interest, which is it's very sad. There's great inequity. You know, Latin America is the greatest, the region of the world with the biggest inequities. It's not probably the poorest region of the world, but it's the most inequity, the most unequal, sorry. And you are seeing that with the COVID pandemic, because many countries in the world, some, for example, Argentina, have the higher rates of mortality for COVID. So, and also the lack of systematic reports of the level of quality of care. I hope that you are familiar with the HQSS report on the quality of health systems in developing countries that was published in The Lancet in 2018, that describes inequalities around the world and the importance on trying to reduce those inequalities by providing evidence and reduce the gap between evidence and practice, as I mentioned at the beginning. And the whole Latin America is a little more than the population of India. So, and that's distributed about a number of countries, about 30 or more countries. And I understand that India has lots of states that also have different realities and fragmentation of care that happens in Latin America. So from ISQua and from the local network of people interested in quality of care, we have produced a number of publications that I'd like to share with you about either the pandemic or patient safety or in case of infection control. And at the beginning of the pandemic, some of us make a call to action trying to incorporate quality and patient safety policies to address the COVID-19 pandemic. Try to strengthen care, especially for vulnerable populations, trying to reorganize the flow of patients, to strengthen supply chain systems, promote self-protection of health providers, care for the well-being of healthcare providers, including second victims, and ensure person-centered care with adequate communication between providers, patients, and family. I am sharing this with you as a framework. I'm just trying to bring more examples about the case of infection control and healthcare-associated infections, and again, the case for ICRA. So just trying to share with you, CLABSI, it's an important, it's a frequent and important because of its mortality, hospital-acquired infection that has been around for many, many years as care got more complex. And you may have seen, and here in Latin America, we run a collaborative. A collaborative, that's something that could be also applied to the Indian subcontinent. It's a way of trying to scale up interventions, because the solutions for CLABSI are there. The problems that they haven't been used. And here you are seeing a contour chart on the right, upper right, where we are describing the impact of a collaborative, just trying to apply the evidence to reduce the frequency of CLABSIs in a number of countries, a number of ICUs in Latin America that were over 60. So this was a huge project in 4 countries in Latin America, run by groups of interested in this called CLICS, which is a number of people that have been working for the last 10 years trying to improve the care that's being delivered in our region. Then with colleagues in Argentina, we tried to also improve the case of hand hygiene, running a clinical trial where we with 5 interventions, all based on the evidence, we try to improve the rates of hand hygiene. And here you're seeing the rates of hand hygiene that we found around 9 months, where what this paper adds. Hand hygiene, we have been talking about hand hygiene for years, for decades, and lots of people have even do this for a longer time. But here we found a way to scale up hand hygiene in ICUs that had moderate hand hygiene rates. Because the problem is not to go from very low hand hygiene rates to acceptable ones. It's to go to those acceptable, or that it's not acceptable, 60%, but that could be improved to even higher ones. So this was a very interesting example of how you can improve care while you are doing it reasonably well. You are doing better than your peers, but again, we need to get to 100%. So this is something that we've shown that in transitional countries like Argentina, we could collaborate with the case of hand hygiene, promoting a multidimensional intervention to address this problem. Then I'd like to share with you 2 projects that we have run in Argentina during the pandemic related to infection control. One has ended, the one I'm showing, and the other one it's starting. The one that has ended, this is Argentina. You have seen all the states in Argentina, and you are seeing that we have enrolled 15 ICUs in Argentina that covered in the public sector of Argentina, that this study covered 5% of the ICU beds in the country. As a sample, it's quite interesting. And what we did again is a collaborative, just trying to improve certain outcomes. Like, for example, that 90% of the healthcare providers use correctly personal protection equipment in encounters with patients, achieve a 90% compliance with objectives related to patient flow because beds were needed, and we needed to improve care on the bedside to reduce the length of stay. Then we also provided 90% professionals with an emotional support tool, and 90% performance in patient safety indicators was what we did. We wanted to prevent, not to go below that, because we had the impression at the beginning, and we're trying to also show that whenever the paper is written, that patient safety was another victim of the pandemic. So what we did is we enrolled 14, we lost one along the way, 14 public sector ICUs. We conducted an interrupted and controlled time series, and over 56 weeks, or more than a year, we ran a set of interventions to address these outcomes. And you are the ones that are the first witness of these results I would like to share with you, where this is you are seeing, sorry, it's in Spanish, but from September last year till July this one, we have been running this collaborative where you are seeing on the gray and the black dots that we have almost reached a 90% usage of PPE. And on the red curve, you are seeing the phases of the pandemic in Argentina. So you are seeing that even during high frequency cases of the pandemic, we didn't do that bad compared to the PPE usage, and reaching from the baseline where there was 60% to even 90%. And that meant, it was difficult to measure, but that meant less contagious for providers and even for patients, because we were measuring the right usage of PPE in COVID patients and non-COVID patients. So as you can see, we're just trying to apply the evidence to practice. And you can see that in the last, in this run chart, the last points measured that somehow there was a special cost variation that hopefully made this sustainable a long time. And whenever we were exploring the causes of EPP misusage, again, we found high hygiene as the classic the classic situation to blame. And again, it's amazing how we still are not using rightly the hygiene procedures to prevent in COVID, even where healthcare providers were so scared to get from patients, we're not using the right way in hygiene practices. Whenever we're talking about the daily goals checklist, this checklist is composed by a number of questions that every ICU provider should ask whenever they're facing a patient. Is this patient needs still a central line? Does this patient still needs a urine catheter? As this patient eventually needs to be transferred out of the ICU? Does this patient has his bed at 45 degrees? The head of the bed is at 45 degrees to prevent pneumonia associated to ventilators. So those kind of questions that are usually asked by ICU's providers that should be used consistently in every patient. These were 9 questions that should be used in all patients all days. So again, we reached for something that was unusual for ICU providers in our region, in our country, to be used. And again, we found the chance of trying for this to be improved a long time, and again during the pandemic. So as you can see, again, a special cost variation is present. Finally, this is nothing related mainly to infection control, but you are seeing here that the number of people reaching out for emotional support wasn't that high, and here we failed because we kept our rates at 8% and we wanted to reach 90%. So here we couldn't find a way to provide emotional support for healthcare workers during the pandemic. So we'll try to go faster. Finally, my last message is on antibiotic stewardship. I would say that the case is that infection, antimicrobial resistance will increase after the pandemic because antibiotics will use in a way that maybe wasn't that controlled because of course providers didn't know what to do with these patients that were very sick and treatments were not available to support them while they were transiting their COVID infection. So again, we are seeing another chance of improvement. And another project that we are starting in Argentina is trying to address the COVID aftermath. Whenever patients will eventually will be affected by a number of infections that that will affect their admission, because being infected by resistant germs will increase the likelihood for them of dying of being affected. So again, we're trying to use an old solution because stewardship programs have been there for years and years, but whenever they're used, they improve treatment failures, they diminish the frequency of C. difficile infections, adverse effects from antibiotics, antibiotic resistance should be even increased, hospital costs and length of stays. This is the perfect business case, and for some reason people are not using it yet. So again, we're trying to run a collaborative in ICUs after COVID, hopefully it recedes, in order to address the case of antibiotic resistance, because we're trying to contribute to the case of infection control and decrease the number of frequent adverse events that are still happening. And you know, in developing countries, hospital-acquired infections are still the biggest threat for patient safety. In developed countries, it's not the case, but for our countries, it's still the case. So as conclusions for my presentation, infection control is a critical component of quality of care and patient safety, maybe the oldest one and the one that we still need to pay lots of attention to. As antimicrobial resistance is becoming even a more important factor for healthcare than in previous years, the pandemic may worsen the situation. ICRA, it's an important strategy to reduce the burden of hospital-acquired infections through an adequate planning and control during construction and renovations of healthcare facilities. QI and infection control can play very well along together, as I showed in the experiences from Latin America. So with this, I'm ending my presentation. This is a final resource that you can find of use, a global reference on ICRA, a very interesting resource that I have been consulting for my presentation, and I hope that could be of use for you, you haven't known yet. And finally, I hope that the shadow, the darkness leave us finally, and we can eventually see each other together soon. Brisbane, it's happening October next year in 22. So hopefully we have the chance to meet in person. That's somehow closer to India than to Argentina. So it will be easier for you to travel over there, hopefully. And again, I'd like to thank CAHO for the chance for letting ISQua to present today. And it's a pleasure for me tonight to address a question. Please, for the people of CAHO, do not ask me the difficult ones now. I can address them, some of them by writing after this. And thanks again for the time today.
Thank you so much, Dr. Garcia. It was a wonderful lecture. I think you took us through a wide variety of infection control, from facility planning to hand wash to antibiotic use to PPE. Before I go through the questions in the chat, as I go through them, if you were to pick, based on your wide experience and projects across Latin America, as a healthcare infection control leader, 5 places or 5 things in the hospital which you would probably start off with first in your infection risk assessment, which would they be? The top one comes to your mind.
No, I will tell you the top one for me. You know, I don't consider myself an infection control leader. I work with infection control leaders. And you know, the root cause of infections, it's leadership. If leaders in hospitals do not talk about infections, that's the biggest problem, because they will not support all the other things that we all know that we should be doing. ICRA for construction, surveillance. But if you need to convince a hospital leader about the importance of infection control, that's it. So I'm trying to simplify, because you have then all the most important infections, hospital-acquired infections that are occurring, like CLABSI, pneumonia, associated to ventilators, associated to urinary catheter, surgical infections. You know the list better than me. But again, so supporting the people that know what to do is, for me, the critical aspect of infection control.
Thank you.
Thank you. Well,
yeah,
lots of people, lots of questions. So how would you like to address those in the few minutes that we have?
Yeah.
Here, Loku, sorry.
Would you like
I can go for
I would let you take which are the ones which you think are already.
Let me see the ones I maybe can answer easily. Long-stay in hospital not considered a hospital-acquired infection. I don't know, maybe I was misunderstood. Hospital-acquired infection extends length of stay, and that could be prevented. Okay, so that's a clear point. I'm sorry, Loku, if I couldn't express myself more clearly. Well, reuse, you know, we published a paper in reuse about a number of years ago. That's a problem, because, you know, it's difficult to play the role of a developed country service delivery in poor countries like ours. So I would say that reuse and remanufacturing are things that should be discussed and regulated by countries. So again, reuse is usually not very safe, but remanufacturing should be addressed somehow. So I have the sense that there's some plants around the world that are already into this, and they're doing that safely. But again, manufacturers usually say that they have not built certain devices to be reused. So we need to be very careful. And if you're reusing something, try to clearly understand how it could be reused and what's the safest place to do that. If not, you're putting your patient at risk. Sorry for Anke, I cannot answer the window air conditioner. If you like, you can write me and let me know about this to maybe find the right answer. I couldn't find a paper that described how many hospital-acquired infections could be prevented by their appropriate redesign. I would say that any one that could be prevented justified doing the right things the right way, but I couldn't find that, you know, one thing for us, for all of us, is that we cannot still sell the business case of quality of care, and that's incredible, especially for infection control, because it's still, we need to convince people that this is important. So I don't have a figure for that, Mirta, but I have the sense that it's not small.
थोड़ा सा जैसे किसी को भी हो जाता है ना कि हमारे सेम
There again,
थिंग हमने उसके साथ भी यही हुआ.
Sorry. Okay, well, good. Sorry. I have the sense that the catering area also provides some risk. So Shana, so I have the sense that also that should be considered. Maybe you should look in depth in what I share with you as resources and activities for different risk areas of your renovation. As I mentioned to Anke again, sorry, hi Anke again, the high-risk areas are the ones that are related to patients are more in danger of being affected by a non-resistant or multi-resistant germ in the hospital. Well, to Ahmad in Indonesia, what can I say? You know, COVID changed all things. And, you know, this is work in progress. I'm sure that not many hospitals have been renovated or built during, well, some hospitals were built from scratch during COVID, but I would say that most renovation and construction may have stopped. So we'll see how it goes. I don't have an answer for you on how COVID have eventually affected the way these were delivered. Well, I believe I have provided standards for ICRA. Again, to Anke again, the list is on the presentation. To Sonali, I'm not familiar with PCRA. I believe I haven't used that acronym in my presentation. BSI, sorry, Loku, I don't remember that acronym in my presentation. Maybe it was in one of the smaller tables. You can reach out for me by email and try to hopefully try to address that. Someone that could introduce himself or herself. There are many checklists and resources that I share with you about how we should monitor ICRA. Again, the hygiene audit were done as usually been done through observerships, people that have been observing your colleagues and try to address what kind of failures they have in their hygiene practices. No one ARIS has eliminated COVID in their hospitals. We just try to reinforce process measures to prevent COVID to be transmitted in the hospital. That's something that lately we understood that healthcare workers acquire COVID at home or during transit, not particularly at the hospital. So well, eventually that still needs to be done, but the risk is mostly outside. So for Thomas C, the emotional support tools, you know, they were designed by a Spanish researcher from Spain. I will put in the chat. Well, I cannot. There's a chat. I don't know if people could see my chat. So to everyone, we'll put it in Spanish and in English. You can find it in the Apple Store.
I think the webinar itself is one of the collaborations that he's talking about in terms of how do larger groups collaborate across countries and across platforms.
Oh, yes, it's a no. I mentioned because there were some support tools that that could be used for providers. They're built in Spain for Latin America, but we'll see how they could apply to other regions of the world. Well, Akio agrees it must be from. Well, I would say that to Akio, I will answer that regulation is the key. If the governments do not support regulation on this will not happen. The ICRA team, it's everyone. It's leaders, builders, planners, infection control specialists, and clinicians. Well, then we have Luciana from Brazil. She's a leader from Brazil, a great leader from Brazil. Luciana, she's a critical leader in our region. She's she's sharing that the science of human factors implementation and engineering has to integrate different aspects to build a more up-to-date strategy for infection control beyond the use of traditional epidemiology. Luciana, from what I read preparing this presentation, I believe that somehow it's happening because human factors and engineering are trying to work together in trying to redefine the way healthcare is delivered. So I'm positive about that's happening, and it will take time for sure. Rebati, you are having you have in the resources I share with you lots of forms and information. And I have the sense, Juwata, that laboratory infection control policy refers to how laboratories are preventing infection ways of identifying ways of infections to ensure in the resources that I share with you, there are more resources for you to look for. Well, Dotin Tom mentions the reuse of single device. As I mentioned, be careful. It's something that it might be done, but it should be done very carefully. Well, for Samson, I would say that what I learned from infection control specialists is that in every setting that you are, hygiene is the most cost-effective way of preventing infections. It's a huge step for, besides other things that may be more expensive or more difficult to get, but hygiene is the most critical. Well, I believe that we have reached the end of the webinar. I don't know if this is hopefully what you were looking for. I hope that I have delivered things that could be of use for your audience. It's a pleasure and a privilege to share this with you. I thought that we will be talking mostly to attendants belonging to the Indian subcontinent, but I see that CAHO has a global audience, which is amazing. So congratulations for that. And I'm proud that ISQua and CAHO are joining forces, and it's a pleasure to collaborate in whatever you need for the future. Thank you so much.
Thank you, Dr. Sandeep Murali, for moderating the whole session. It was very nice. And thank you so much, Dr. Ezequiel, Garcia-Elorrio, for doing a great webinar today. I think it has generated a lot of interest in our audience. And we had so many people joining across the globe, nearly more than 500 participants here, and everyone watching on YouTube and other things also. So it was really great. And we would love working with you again in the near future. Garcia, I would like to ask Dr. Vijay sir to present this certificate of appreciation. Sir?
We are honored to confer to you this certificate of appreciation, Dr. Ezequiel Garcia-Elorrio. We really enjoyed your talk today. Thank you very much.
Really a pleasure, and I hope we can meet in person soon.
In having a wide audience because of our partnering with various, we have various collaborations with ISQua and ISQua and other international bodies. And thank you, Dr. Ezequiel, once again. And thank you all, and a great evening. Thank you so much.
Thank you.